we're going to talk about IV fluids and why patients have IV fluids, maybe what are the different types of IV fluids, and what should a nurse monitor for when a patient has IV fluids ordered and infusing. So let's continue and understand IV fluids a little bit better. So why IV fluids? Well, there are four main reasons why we need to give somebody fluids through their veins. We're bypassing the stomach, we're bypassing the whole GI system, and we're going straight to the veins to get the body what it needs. The first and most emergent reason why we would do it is because of fluid resuscitation, meaning somebody has got massive bleeding, and we need to restore the circulation to the vital organs, because if those blood cells don't get around, then body starts shutting down. So a lot of times the volume must be replaced. Also, another reason you have to do fluid resuscitation is like an extreme burn victim. Whenever the skin is gone and all of the what's that tissue? It's not the subcutaneous, dermis, epidural. Yeah, one of the layers of tissue is just exposed, and all of those capillary beds literally will just seep plasma out. And so they're going to lose that volume, and therefore the vital organs are not going to get anything to them. So we have to replace everything that's grossly lost. And even in sepsis, whenever somebody gets an extreme infection, all of the fluid will actually leak right into the body tissue. So we need to resuscitate this person and put the volume back in. So this is a straight volume loss, volume replace problem. And generally when we fluid resuscitate somebody, it's an emergency situation. One of the most common reasons why you are going to give IV fluids is for just routine maintenance. So this is when somebody simply cannot meet their normal fluid or electrolyte needs by taking fluids in by their mouth, or if they have a PEG tube or a G tube through their stomach. They're otherwise well, in terms of fluid and electrolyte balance, but I believe there is a little formula on page 225 in the second column, last paragraph, that talks about your daily water requirements. Now, it completely differs by age, by weight, by medical problems. However, if somebody's NPO, their body needs fluids on a daily basis. So we are going to just routinely figure out how much they need, calculate out, and we're going to give them what they would normally be drinking. Some patients come out of the OR and need just to be put back on some IV fluids until their gut is awake and the person can start tolerating a diet. So routine maintenance is probably the most common reason you're going to see somebody on IV fluids. Just to clarify again, nothing is particularly wrong with the gut or wrong with a person. They are, electrolyte balance. They just need everyday fluids coming on in. So that's why we're doing it. Our third reason is replacement. So this somewhat can sound similar to the resuscitation reason, but it's not exactly emergency situation. So a person will have intravascular fluid loss for reasons that are not exactly urgent. So say they've had lots of diarrhea, lots of vomiting, and so we need to, they're not in a critical state of hypovolemia necessarily, but we do need to get fluids back in their body, even through insensible fluid losses. So somebody's hyperventilating, or if somebody has a fever, in fact multiple fevers, they are losing fluid, and so we just need to restore some of the volume that is lost. I will say what's interesting about just replacing fluid that's lost is they have to be kind of careful, because the body many times adapts, because this fluid loss occurs slowly, and so the body will actually start implementing compensatory adaptations, and so whenever you replace this fluid, you just have to be very careful and watch for the electrolyte imbalances, because the body can somewhat be a little resistant because the changes take over, maybe a few days to like a week for it to start adapting, versus here, what's lost, you just replace in bulk volume. Here, you have to really pay attention to like the electrolyte imbalances. Our last and final reason, redistribution, is kind of complicated. In fact, the patients who have fluid issues that the body has redistributed where the fluid sits in the body, these patients are normally in the ICU, and they have to be watched really carefully. In fact, the electrolyte imbalances are pretty extreme. You have somebody with liver failure, so a lot of times the fluid that should be intravascularly or found in the intravascular system will be like in the peritoneal area, so they'll have what we call ascites. Or if you have somebody who's got a really bad heart, the fluid will probably be in the tissues, like in their feet, their belly, their hips. So the cavities are going to be holding the fluid. So the person is not, in a sense, completely dehydrated. However, the fluid is in the wrong place. So in a sense, they are. So you have to give them very particular types of solutions to try to recorrect the redistribution. This one's kind of the complicated one. Why you would replace IV fluids. Okay. Now you know why. There are several different types of fluids that we can give people. Now, everything is compared to the osmolarity, which is pretty synonymous with osmolality. In fact, I'll say those words back and forth. It pretty much means the same thing. But anyway, you compare it to the osmolality of the blood. So what is the osmolality of the blood? What is the osmolality of the plasma? And then you look at your solution, and then you compare the two, and you say, okay, this is, isoosmolar, which is the exact, same molecular weight. Or if it's more water and less solutes, then it's hypoosmolar. And then the other one would be the reverse. There's more solutes compared to the water, hyperosmolar. We, instead of saying hyperosmolar, we'll actually use the word tonic. So we'll say hypertonic fluid or hypotonic fluid or even isotonic. Let me go ahead and move forward so I can actually explain the differences of one over the other. So here we have the different types of IV solutions that you can be giving somebody. The most common ones that you are going to give are the crystalloids family. And within the crystalloid family, there are 3 different types of IV solutions. Normal saline, sound familiar, or 0.9% sodium chloride? Well, that is considered an isotonic fluid. If we actually half that amount of saline in there, so not 0.9%, but now make it 0.45%, we say half saline. That actually is going to make it hypotonic. So it's actually got less solutes in it, and I'll describe in a second what the effect is on the patient whenever you give them that kind of solution. The other one is hypertonic. So let's add a little bit more sodium into that fluid. For an example, say 3% saline. This is a very dense, figuratively speaking, type of fluid. What effect is that going to have on the body? So just know that there's 3 types of solutions. There's several different types of mixtures. I mean, goodness, there are probably over 200 varieties of combinations that you can give somebody in terms of what kind of crystalloid the person could get. So that's a lot of different combinations, and you don't have to know them all, really just kind of maybe the basics that I'm going to describe in a second. The other type you have is a colloid. These are fancy, and they can be human product, such as a spin-off from human donated blood, or it could actually be a synthetic product. But generally, these are known as plasma expanders. And so in nature, they are hypertonic because they have large amounts of protein or other molecular substances in it. And it is going to make your intravascular volume grow. So it's actually going to be sucking fluid either that you put into the body through another vein or fluid that's inside the cells. It's going to be pulling it back into the venous and the arterial system where it should be. So very short-lived though. That's the bad part about the colloids. They don't float around long enough. You'll see your effect in 1 hour basically, then it's gone, versus the other fluids. But anyway, another one that we have is lipids. So yes, you will actually give somebody fat. So if a patient can't take any PO intake, any kind of nutrition, after 7 days, you're looking at possibly starving somebody. So you have to provide their body energy and carbohydrates, and you do that by infusing total parenteral nutrition, or we say TPN, and part of the TPN has electrolytes, carbs, proteins, and then the lipids, the fat. What's crazy is you actually have to monitor somebody's cholesterol level because you can give them too much lipids, and that's equivalent to eating a burger more or less if you're not paying attention and eating a lot of burgers. Send them to the cath lab, why don't you? And then of course our last one is blood products. This is kind of like an eye for an eye. So this is whenever somebody is needing fluid resuscitation, and then you're going to give them blood or blood products such as FFP or plasma. And those are considered, I believe, isotonic type of fluids. So it's crazy. So you have the clear stuff, and then you have all the little derivatives, and they all have the tonicity. Colloids are hypertonic, lipids are also hypotonic. Did I say hypo? These are hyper, excuse me. And then this one is isotonic. But anyway. First, I want to mention the crystalloids, particularly why we're going to do it. So you know your reasons. We're going to initiate crystalloid infusions generally for replacement and maintenance therapy. And in emergency situations, you would do for resuscitation as well. But more commonly, it's just for replacement and maintenance therapy. Let's discuss the isotonic solutions first. So here are 3 examples: LR, D5W, which it stands for dextrose 5% in water, and normal saline. Now, many times when patients come into the hospital, they actually won't get LR. Generally, they use LR for surgery cases. So a person will go and have LR infusing before surgery and when they come back from surgery. But pay attention because the doctor usually changes after they've infused 1 or 2 bags, or I should say liters, of lactated ringers or LR. But when we give LR, we do need to pay attention that it has some electrolytes in there. It's like prepackaged. So there's calcium in there. That's important because a lot of medications are incompatible with LR. So say you have LR hanging up there and you need to give Rocephin. Well, Rocephin's an antibiotic that's incompatible with LR. And the reason being is because of the calcium inside. So be aware of medication compatibility when you think LR. Another thing that it contains in there is potassium. It is a potassium-rich type of solution. So there, I know we haven't gotten a chance to cover this, but kidney patients don't exactly excrete their potassium like they're supposed to because they have the kidney failure, the kidneys are impaired. So when we give LR, either it is contraindicated or we have to be very cautious when we give it to somebody with kidney problems because we're putting them at risk for hyperkalemia or too much potassium. So be very, very careful, and if possible, don't do it if you're not closely monitoring their electrolytes, such as drawing blood work every morning. Another thing, too, is that it doesn't exactly contain sodium bicarbonate in there. However, if you have somebody who's at risk for metabolic alkalosis or respiratory alkalosis, either or, and we start infusing LR, we're actually going to be giving them substances that the body is going to take and do its chemical process and make more sodium bicarbonate. So we can actually put somebody who's at risk for metabolic alkalosis into true metabolic alkalosis because of our LR. Do you know some situations or risk factors for metabolic alkalosis? Think. Okay, so if you came up with something along the lines of, say, somebody ingested too much antacids, or they're getting multiple blood transfusions, they could possibly have prolonged vomiting, that person is probably at risk for metabolic alkalosis, and therefore giving them LR would probably be something along the lines of a contraindication. So got to double check your ABGs just to know where somebody stands to see if their pH is already high, because we're going to make it higher. Another solution that we can give somebody for maintenance therapy or replacement is D5W, or dextrose 5%. So this is great because it provides somebody who's NPO, we just need to meet their daily fluid needs, some extra calories. So not only is it giving them some fluid, but it does provide some calories. This is really very beneficial, especially when somebody comes out of surgery and they're not eating just yet. Then we have your typical normal saline. You're going to infuse a lot of normal saline over your future career. This is mainly to recorrect dehydration. So somebody is a little bit on the dry side, their mouth is dry, their eye, not the mucous membrane of their eye, but you just tell they have drier eyes, their skin turgor is really loose, they're not peeing as much. In fact, if you were to grab a urinalysis on them, their specific gravity is going to be really high. In fact, 1.030 is considered too high. So somebody is actually starting to conserve their urine, and they're not releasing any free water, and the body is just peeing straight waste. Like, I can't spare any more water. The easy way to remember the upper level for specific gravity, and this is how I remember it, you can take it or leave it, whatever you want, is I think of, if I don't have any input in the morning, by 10:30 a.m. my urine is going to be really dark and really concentrated. My body is starting to go into conservation mode. So that's my little way to remember the upper level for specific gravity. So it's too many solutes in there and it's really dark. So anyway, so if your specific gravity is high, you're going to start infusing some normal saline. And it also helps with sodium depletion. So somebody has a condition, maybe even usually acute kidney problems, acute renal failure, I should say. They're going to have trouble conserving their sodium, so they're just going to pee their sodium right on out, as well as the other waste. So we're going to infuse some saline for this person. Some nursing considerations. In general, when you're doing any kind of IV fluids, in fact, they have an IV, great, but as soon as you start connecting fluid to it, you should literally do every single one of these. So they're not going to vary substantially between the crystalloids to the, blood products and the hypertonics. They're kind of the same, actually. So if you learn these, you should be good for all of them. Weight changes, we should be doing daily weights on our patients. In fact, anybody in acute care should be getting a daily weight, and that's done around like 6 or 5 in the morning. The beds are kind of fancy and they can weigh the patient. You just have to take so many pillows and blankets off before you weigh the bed, because a lot of times patients add stuff to the bed. We need to always be assessing their mental status, and what we're looking for is changes. They should be having an improvement in their confusion, or as the sodium kind of readjusts, because sodium is a big role in somebody's mental status. So as the sodium normalizes, they should be start coming to. Headaches. They shouldn't be having headaches. If they have a headache, that actually means there's too much volume inside their whole intravascular system. So basically their veins and their arteries inside their heads are expanding, causing pain. So double check the mental status. Ins and out, not only isotonic, but all fluids. We should be checking and making sure that, okay, I put 1.5 liters in. How much urine came out? Oh, only 300 milliliters. Well, there is a problem. So it should roughly be within 400 to 200 milliliters, and that's just in a 24-hour time period. So there really shouldn't be much difference. In fact, for patients who are severe heart failure and severe kidney and liver failure, basically that kind of just labels everybody, but there's even tighter margins. So really you should only have like a 200 milliliter difference in the I's and O's. And if you want to ask, well, where is that 200 milliliters? Well, don't forget there is insensible fluid loss. So what you breathe, you're actually losing fluid through your eyes and through your sweat. But I don't sweat, Miss Tonis. Well, you do. You do. Change position slowly. Whenever somebody doesn't have the correct fluid volume in their veins and their arteries, when they change positions, well, it may not exactly keep the pressure in their head because gravity happens and your muscles are squeezing in different increments. So a lot of times your patients who are hypovolemic and receiving IV fluids are more prone to be feel dizzy when they stand up or change positions. So while somebody's on IV fluids, just note that we're talking volume differences and they need to move a bit slower, so they don't need to hop up out of bed necessarily. Oh, and fall precautions because of this reason. So these two are kind of linked together. Use your call bell, bed in lowest position, hourly rounding, those are all fall precautions. Alright, I think I beat this horse pretty good. Another type of crystalloid we can administer to patients are hypotonic solutions, such as half saline or D2.5W. This is important to administer to patients when a patient has intracellular dehydration. Well, my goodness, how am I supposed to know if my patient has intracellular dehydration or not? A lot of times it's based upon the diagnosis, such as diabetic ketoacidosis, or the fact that they may have heart failure. What's really kind of interesting about giving somebody a hypotonic solution is that this solution actually causes fluid that is in the intravascular system to move into the cells. So we are actually more or less putting fluid into their body that's going to be transitioned right into their cells, not so much in their bloodstream. You would think it's all one place, but there's definitely a lot of compartments inside the body. What's important to know is that we can make somebody a little bit more dehydrated if we give them this solution because the fluid is going into the cells. In fact, I have a picture of a hippo here because I want you to think hypotonic solutions cause swelling. Hippos, big, cells are swelling. That can help you remember this maybe a little bit better. Monitor for weight changes. This kind of goes for any time you're giving somebody fluids. Our mental status may change if they are becoming, with an electrolyte balance. The ins and outs should be the same. If I'm putting 500 mils in, I should be getting anywhere from 450 to 500 mLs out. Change position slowly just to prevent the hypotensive orthostatic hypotension that may occur. Hypertonics are other types of crystalloids that we can give to patients. Particularly they are used when a patient has low sodium. Maybe they're on a certain type of diuretic. Maybe they're on a really restrictive low sodium diet. They could possibly have excessive sweating from fever, from maybe exercising too much. Our kidney patients may not be able to retain sodium or some of the other electrolytes. We could possibly have a patient with that nasogastric tube that's draining them so much. And for all of these different reasons, our electrolytes are off, our volume has been depleted, and we need to replace it in a patient. Hypertonic solutions are the great way to go about this. We can give them D5 half, We can also give them 3% saline. What's important to know about 3% saline is that it is a vesicant, means it does need to go into a larger vessel, preferably a central line, because if not, it can cause pain into the patient during the infusion process. ICP would be intracranial pressure, in case you're curious. So, like many of our other fluids, we can cause a fluid excess problem. And what I mean by this is this solution by nature actually shrinks the cells. Whatever fluids are inside the cells, it pulls them out of the cells into the vascular system, as well as adding to the vascular system. So it's a little bit of a double Dewey when we are trying to resuscitate somebody with fluids. I have hypertonic here, and I have somebody who's hyper and skinny to try to illustrate the concept of what is going to happen to the cells. Our big idea here is that overhydration is a common problem. How do I know if my person's overhydrated? Well, they'll have signs and symptoms of fluid overload, such as tachycardia, decreased urine output, increased kidney function levels, such as the BUN and creatinine. The creatinine will be greater than like 1.8, then our BUN greater than 20. Pulmonary status, they'll start to have respiratory distress in their crackles in the lungs. JVD will show up. We'll see that they actually have gained some weight here, maybe a pound or two. As the pattern continues with different fluids that you're giving patients, a lot of times your interventions will cross over, such as assess their behavior status, make them change position slowly. Here is the last slide I'm going to cover for you guys, and this is colloids. Very rarely, actually, will you give this. However, it does come up in some cases. Generally, you're going to be, say, in the ICU, or you're going to be caring for a patient who has liver disease. And in that event, they have a problem processing protein, and so their albumin levels are consequently always low, and therefore always having a lower blood pressure, because what's great is albumin, this protein, has like an ability to allow water to follow it. So if you have low albumin, therefore you're going to constantly have a water problem or volume problem. When I say water, I mean, the solution or plasma inside your body. So you're going to give it to people who need volume replacement, like your liver patients, and folks who are in like hypovolemic shock. So they come in either from trauma or from sepsis or even anaphylactic shock, and you need to give them some volume so their blood pressure stays up and everything like that. So the first thing you can give them is dextran. What's cool is it's synthetically made. You wouldn't like to give this through an 18 gauge needle or larger, or even through a central line. It's not a vesicant or anything, but it's got some pretty heavy proteins in there. So they're large and they can be infused rapidly. You just have to push it through a big needle. It doesn't have any oxygen carrying capacity, so yes, it is, in the family of blood products. It's not from a human, it's synthetic, remember, but don't give this and think, oh, a person who's in, say, cardiogenic shock because they're bleeding out, that you're going to correct the volume part, but not so much the anemia and the hypoxia part. So in that case, you could give them dextran and blood. Sometimes if you're out of O-negative blood and you haven't typed and crossed the patient yet, you can give this as a substitute until you get your blood ready. Make sure that you draw the type and cross before you give the dextran, because it's going to interfere with the cross matching. So trauma situation, you immediately draw some blood and then you give this dextran. Like I said, it's mostly given in the ER or even like the OR in case a patient crashes there. Now, albumin. This is from human blood. In fact, whenever you go and donate plasma, they'll spin off the albumin, that's the protein off of it. If you give it to somebody just to you know, replace some volume. We actually give this a lot in interventional radiology when we would do a paracentesis. It's really kind of crazy that this happens. So you give somebody, or this person has liver failure, they have really bad ascites, so fluid in the peritoneal area, and we drain it, and the body, this is just weird, it notices and it knows that all of the fluid is going out. It's being drained. And so literally it will, within probably a 15-minute time period, as I'm monitoring somebody's blood pressure, I'll see their blood pressure start to drop. And the reason being is the body, because the liver is dysfunctional, wants to replace the fluid that just got taken out. So it steals it from the intravascular, from the veins and from the arteries. And so somebody's blood pressure, I have to monitor it pretty closely, is going to drop. If it drops too much and the patient starts becoming symptomatic, the doctor will order me at that time to give albumin 5%. If we have somebody who is got too much swelling in the cells, they will actually order a 25%, like when I say swelling in the cells, like the ascites is too bad and our 5% is not doing anything, they'll actually increase the strength. And be careful, anytime you give hypertonic, you've got to watch for fluid overload. And this one is, I believe, hypertonic as well. So head starch, this one doesn't come around very much. However, it's synthetic. It's closest, matched to albumin in terms of how it works. What's cool about this, if you give it during a resuscitation period, it actually stays in your system about 24 to 36 hours. So that's a lot longer than all of them. So nice, very nice. And if you're in an emergency situation and they're like, we don't have time to draw blood, we need to give dextran, you can suggest, well, how about some head starch? And yep, all of these, if your patient has heart failure, the heart cannot handle a lot of times these extra fluids. So you either don't give it or you give like barely any, like half of what the normal prescribed dose is. It's very, kind of a touchy situation, and your person probably is going to be in ICU because when they crash from having too much fluid, the respiratory system's going down and the cardiovascular system's going down right behind it. So they need to be really closely monitored. I believe that's it. Just make sure you always weigh, always checking for hydration status. Are you dry? Are you too wet? Sorry about that. And I think you're good to go on this. Any questions? Use the discussion board.